Hello, everyone, and welcome to GRM and Forrester's webinar on the 21st Century Cures Act. We will be talking today about the implications of the Cures Act for active patient data or records. That is those records that are in your current EHR platform, as well as archived patient data, maybe data that is older records that exist in a former electronic health record platform that you have or in an archive environment. Please feel free to enter questions in the panel to your right, and we'll cover those questions at the end of the webinar. With me today are Shannon Germain and Kyle Rybarczyk, both from Forrester. They are both senior analysts for healthcare strategy. Shannon, prior to joining Forrester, was a contact product architect at Change Healthcare and was also a clinical content developer where she created medical criteria for their clinical decision support tool with Interqual. Shannon holds a BS in nursing from Fairfield University and an MBA from Northeastern University with a concentration in healthcare management. Kyle is also a senior analyst for healthcare strategy at Forrester. He served 10 years in the U.S. Army's Medical Service Corps, where he monitored and analyzed medical data of large-scale teams, planning and administering programs and services for Department of Defense health systems. He holds an MS in forensic science from the University of Illinois at Chicago, a BS in chemistry from Carroll University, and an AS in health science laboratory technology from George Washington University. And now I'd like to introduce Kyle and have him go over the particulars of the 21st Century Cures Act.
Thank you, Jim, for the introduction. Shannon and I are very excited to be here with you today. So as you said, I'd like to just set the stage and give a brief overview of the Cures Act and what it means in terms of interoperability, information blocking, and the Health IT certification program. As many of us know, the Cures Act was originally signed into law in December of 2016 by then President Obama. This was in response to the already $36 billion spent by the US government to help with the digitization of medical records. Although this digitization process helped to unleash an incredible amount of data, many of the electronic healthcare record systems were not and are still not interoperable to this day. The electronic health records within these systems consist of pieces of health information that are presented in multiple ways and recorded in a myriad of formats. Examples include patient names, dates, diagnoses, medications, vital signs, and the list goes on. In order to get the complete patient picture, all of this information must be corralled and put into a standard format. Only then can it be fed into algorithms and provided back to the physician so that the care team can make an informed decision. This is the goal of the Cures Act. The final rule calls on the healthcare industry to adopt standard application programming interfaces, or APIs, to help allow individuals to securely and easily access their health information using smartphone applications and at no cost to the patient. Its second purpose is to improve innovation and competition by fostering an ecosystem of new applications that provides members with more choices in their healthcare. This is a huge opportunity for developers to work with providers and payers to help build the technological architecture for healthcare apps. These apps will be able to aggregate data from members and have the potential to build population health and data analytics tools that will help transform data into action. As part of the bill, the U.S. Department of Health and Human Services and the Office of the National Coordinator for Health IT, or ONC, had to create final rules to help make new EHR technology become more interoperable. These final rules came about 4 years later, after some COVID delays, in March of 2020, and involved two main policies. The first was aimed at electronic health record certification program changes, and the second was to implement information blocking provisions for those who failed to comply. Let's dive a little deeper into these changes to see how they'll affect us. The EHR certification standard changes, which would be called the 2015 edition Cures update, include two new technical certification criteria. These new criteria were designed to advance interoperability between certified health IT systems, make it easier for patients to access their own electronic health information, and help to make this process more secure. The first of the new technical criteria is an electronic healthcare information export rule. This focuses on the ability of a patient or provider to export electronic health information that is being stored in certified health IT. This supports patient EHI access requests, as well as supports healthcare provider interests in exporting an entire patient population when there's a transition from one healthcare system to another. Again, the idea here is to make it as easy as possible for the patient to access their medical records via a phone app, and also reduce the administrative burden on our clinicians. The second technical criteria was the standardization of APIs for patient and population services. This requires that certified health IT utilizes the HL7 Fast Healthcare Interoperability Resources, or HL7 FHIR standard. Two types of API-enabled services are required for this criteria and include services for which a single patient's data is the focus, and services for which multiple patients' data are the focus. This type of standard will allow for interoperability across the healthcare ecosystem, as all systems will have a universal API that will allow them to exchange data. The second rule that came from the decisions of the HHS and the ONC addresses information blocking. Information blocking applies to health IT developers, information exchanges, health information networks, and healthcare providers. It is the act of knowingly interfering with the access, exchange, or use of electronic health information. Essentially, it is ensuring that health IT and those who use it follow the new interoperability standards being laid out in the final rule, and do not put an undue burden on the patient to access or use their own healthcare data. Examples of information blocking include restricting or slowing down a patient's access to their EHI, or using your certified health IT in a way that could lead to fraud, waste, and abuse of resources. Now, there are some exceptions to this rule, and in fact, there's 8, and I have them listed here for you. These 8 rules are typically split into 2 different groups. The first 5 on this list are exceptions that involve not fulfilling requests to access, exchange, or use EHI. The last 3 on here, or the second group, involve the procedures behind fulfilling those requests. The preventing harm exception is considered when we believe that EHI may cause harm to a patient or another person. For example, if we know we have a patient that has been diagnosed with depressive disorder and has had suicidal ideations, it may not be in their best interest to see their cancer diagnosis on their phone prior to talking to a doctor. The privacy exception would be considered if it is believed that fulfilling the EHI request would violate an individual's privacy. For example, a patient could request that their health information be sent to a third-party app, but this app might not have proper HIPAA compliance. This is where the privacy exception could come into play. The security exception is very similar in terms of using third-party apps, but is more meant to cover the integrity of the EHI. The infeasibility exception is considered if the request is just not going to be possible. For example, we all know that natural disasters happen, and there's the occasional public health emergency occurring. This exception would make it so that the healthcare organization would not be liable for filling requests as quickly as possible. The health IT performance exception, which is the last of this first group, is met when health IT is undergoing routine maintenance or upgrades. This exception is obviously needed, as we know technology always needs a little help at some point during its life cycle. The first of the second group is the content and manner exception. This is slightly different in that it says that we can limit the content needed to be given when an EHI request is asked for. It also says that it doesn't necessarily need to be fulfilled in a specific way. So, for example, if a healthcare organization cannot produce, say, a CD with a health record, which is what the patient is asking for, it doesn't need to do so, but it does need to talk with the patient to find a way that is acceptable to them. The fee exception allows for fees to be charged with a reasonable profit margin for accessing, exchanging, or using electronic health information. The key here is that this is only for exporting the EHI to non-certified health IT, as certified health IT must do this for free. And again, we want no cost to the patient. The licensing exception is very similar, except it deals with the interoperability elements of the EHI. This goes back to the fee scenario, but is for a much larger purpose. Now, in terms of a timeline for the implementation of these new certification standards, we're actually already past the middle point. Information blocking regulations have been in effect since April of 2021, although no penalties or punishments have actually been given out yet. This is due to the lack of guidance from the Office of Inspector General. However, there has been a total of 413 information blocking claims, with 381 of these being investigated as legitimate. It's also interesting to note that the overwhelming majority, that is over 225 of these claims, have actually come from the patients themselves. So the patients are aware of these new rules and are willing to do something about their electronic health information. The EHR certification standards for use of the HL7 FHIR API that I outlined previously will go into effect at the end of this year. This means that those healthcare organizations that currently use certified health IT will need to ensure that they have the latest certification criteria if they would like to remain in compliance. The EHI export capability that was outlined must be available by the end of 2023, so essentially an extra year. This was done to help give health IT companies some extra time to comply and make the changes necessary to the systems that they already have in place. Now, the EHI included in these health records is going to change on October 6th of this year, which is just a few months away. Currently, electronic health information is defined in the U.S. Core Data for Interoperability, or USCDI version 1. This was originally based on compliance with HIPAA rules. However, this limit is no longer going to apply on October 6th of this year, and EHI is going to be expanded. This expansion means that electronic health information will include all health information that is individually identifiable, that is transmitted or maintained, either electronically or by other means, to the extent that it would be included in a designated record set. A designated record set is a group of records maintained for a covered entity that includes medical records, billing records, patient enrollment information, payments, and claims. Basically, anything that can be used in part or in whole to make decisions about an individual's health will be included in this designated record set. This is important because this means that all paper records, PDF records, images, archive data, historical data, even legacy data is all going to be included. This requires healthcare organizations to act quickly to ensure that this type of unstructured data can make its way into the system or they risk being accused of information blocking. We've entered into this new and exciting data-driven paradigm. Healthcare platforms will need to accomplish three main objectives. The first is digital optimization and modernization that creates real-time situational awareness for all stakeholders. The second is the optimization and orchestration of business and clinical workflows using operational intelligence and actionable insights. The third is the enhancement of team collaboration through communication, patient engagement, and virtual care solutions. We're moving further away from care confined to hospital walls. With the development of remote devices, telehealth, more interoperable EHRs, AI, and machine learning, healthcare organizations will be able to provide long and short-term quality, cost-effective care for patients with chronic conditions. In order to improve patient outcomes, platforms must support interoperability, and they must support big data analytics. And with that, I hand it back over to you, Jim.
Kyle, thanks so much. That's a great review of the requirements for the 21st Century Cures Act. You know, for the 20 years in my career that I've been a hospital or health system CIO, I've dealt with many times EHR upgrades, replacements, so on and so forth. Most recently, prior to joining GRM, my focus was helping more than 140 hospitals attain phase 1 and phase 2 of meaningful use, which was entirely focused on clinical data associated with our patient records. What the Cures Act seems to me to be is addressing many of the limitations that many of my counterparts in the healthcare world felt that the meaningful use requirements didn't really fulfill. And that's the idea of exchanging information as patients move from one healthcare provider to another. So, Shannon, I guess I'd like your opinion now on just generally the effectiveness of those EHR vendors that are out there now to support the 21st Century Cures Act requirements.
Sure, sure. And I just have a few comments on this slide that you have. It's so simple, but it actually says a lot. And it says free, it says no delay, and it says mobile accessibility. And undoubtedly, Jim, this is definitely going to be a multi-year journey. Kyle outlined that for us very well in the previous slides. So it's going to take time for organizations to really achieve this real interoperability and establish efficient operational processes. And I'll get to my point here, but even just from a high-level marketing standpoint, I'm curious to see how these providers will be looking at getting this message out to their patients, quite frankly, because for the providers that do this well, who do this securely, who do this timely, this will be a differentiator for them, undoubtedly. And then also, it will certainly play into customer patient satisfaction. So, something that I look at very closely and consider, we all should be considering it, is this rise of consumerism and how it coincides perfectly with the Cures Act and what the Cures Act aims to achieve here. So in many instances, and healthcare industry is no different, that this consumerism has way outpaced and has accelerated much faster than digital transformation. So as we continue our discussion, I think it's good for the attendees and for ourselves to just keep in the back of our mind that today patients really take a self-interested, self-educating, self-caring approach to their health. It's a do-it-yourself mentality that patients are coming to the table with these days. Just like we research things as consumers before buying something online, patients are doing that. They are researching things before they approach their own healthcare. They don't want to go any further than their mobile phone, not if they can get something with a few clicks. And then they also don't want to wait if they don't need to. We've got this data point at Forrester where 30% of patients have actually left a physician's office due to the wait. So, there's a lot of synergy here between consumerism and what the Cures Act aims to achieve. So I'm just keeping that consumer-focused, or rather patient-centric perspective in the back of my mind throughout this conversation, and I'll be revisiting that.
Shannon, it does seem like that's been a bit of a shock or surprise to many healthcare providers on how engaged patients are now about this idea of being more upfront about their healthcare, right?
Absolutely. And it's a different approach. It's a bit of a different mentality, but from the vendors and the providers that I've been speaking to over the past few months, they're getting it. It's clicking in, and they're starting to really see how this Cures Act and other regulations is feeding into the rise of consumerism. So I think that's positive. To your questions about EHRs and how they can actually support healthcare organizations, I think there's a few things that healthcare organizations can look out for, especially when considering a new a vendor, quite frankly. First is to help to see what their capabilities are and their willingness is to help migrate to a new system. They should be really critically looking at what programs that the vendor has to offer in terms of assistance with cost and adoption. And some of these vendors are very well established, quite frankly, and they've got good processes down. And then there's the training component and implementation process. So I don't think we should underestimate the customer service and customer support that vendors have to offer when deciding on the next step and which system to move forward with, because we don't want to go backwards to 2009 high-tech days where inefficient operational workflows are adopted.
Right.
We're all trying to get it right. So I think that's something that we've got to keep at the forefront.
That's a great point. So what we also need to think about, though, is for those organizations that don't plan to change an EHR to support this, right? So
Right.
what operational expectations or difficulties do you potentially foresee as a client works with their EHR vendor to upgrade their current platform to be Cures Act compliant?
Yeah, I think there's a loaded question here. So if we, so yeah, we'll focus first on another area that's near and dear to my heart, and that's clinician burnout. And I'll tie that into working with a legacy system here. But I got to bring the data to the table. There's a Wheel study, a study by Wheel that says 80% of 2,000 patients who were surveyed noticed that their doctor was burned out. Let's think about that. And the respondents also said that their healthcare provider was stressed and exhausted, and 70% of patients who noted this said that they were alarmed by it. Let's just keep that in the back of our mind here. So on the daily, because I am a practicing nurse, frontline workers are constantly dealing with changes to platforms all the time. It's part of the job. It's not in the job description, but it is part of the job. Mm-hmm. There's upgrades to EHRs pretty consistently, and these are disruptions, but they're at this point they're expected, and they're what staff deal with on a weekly or monthly basis. We start talking about an EHR overhaul or a new system, that's at the very least 6 months to 2 years in the making.
Right.
So that in and of itself, just the adoption, the endless meetings, the administrative preparation, the coordination that goes on behind the scenes. We just think of how that removes the clinician from the patient, and where that puts them in terms of workload and how it adds stress. Organizations have to be very thoughtful about that when they do make these decisions, and planning has to go on ahead of time.
It seems to me that back in the days when meaningful use was rolling out, the criteria for meaningful use was more about collecting the data, mm-hmm. But not necessarily representing it well in a clinically efficient way, which you call that physician burnout. I've referenced that as cognitive overload many times, right? So yeah. I think you find that a lot of physicians and caregivers in general, nurses, everyone, feels a little bit jaded associated with healthcare technology, right? At least the record-keeping technology portion of it. What do you think of that?
So.
That's kind of
I couldn't agree more. There's a IT overload. I love it. I wrote it down, cognitive overload, because that's what it is, quite frankly. It's just almost too much to bear from a mental standpoint. I think the reason, one of the reasons, I'll let you jump into this more, but I'm thinking about legacy systems and the troubles that healthcare organizations run into here. And quite frankly, I don't know if you'd say it as bluntly as this, but they can be really dangerous for any number of reasons, quite frankly. So if you're you're storing legacy data and obsolete systems, there's lots of dangers to security and data integrity, right? So they're no longer really receiving upgrades, or there's a possibility of them no longer receiving upgrades, right? And I think that just makes them very vulnerable and exposes them to all sorts of cyber attacks or hardware failure. And now, as I'm saying this out loud, I wish I came to the table with some data points that we have on cybersecurity attacks and how prevalent they are. Although I know there's healthcare organizations on the phone here are not oblivious to these. I know it's on everybody's mind.
Right. So yeah, it's interesting. We talk with a lot of clients when we get into this idea of legacy data who are still maintaining an older EHR platform that they're no longer upgrading. They may or may not be paying maintenance on that. You know, it's a way to reduce cost and not pay maintenance, but they may be. We've talked to clients that are still running these systems on, you know, a Windows 2000 environment, which
Yeah.
we all know has, you know, pretty severe vulnerabilities associated with it. So your point that that data is at risk is very poignant, is very real. So while we still are talking about our active EHR and the current EHR that our organizations are using, you know, they are reliant upon the EHR vendor to put the processes in place, the technology in place to support those Cures Act goals, right? So they
Yes.
need to participate in a proper API and you know, be able to integrate down to sharing records with a non-affiliated organization or to the patient themselves, i.e. via a mobile app, right? But now you talk about the legacy data, and I'm specifically calling it legacy data, not archived data. That legacy data that is maintained in an older EHR platform, I suspect that very, very few organizations are planning to reach out to their legacy EHR vendor to do an upgrade to make that EHR platform Cures Act compliant, right? So as we see here in this graphic, that legacy patient data now is sort of broken. There's not a clear conduit for getting that legacy data to a patient or another healthcare provider. Whether that data is 6 years old or 6 months old, you know, depending on how recently you've upgraded to a new EHR platform. So we see that the Cures Act is really going to call attention to that, to those organizations that are keeping their legacy data in that older platform. And it's almost forcing their hand to do something different with it, right? And we know that our typical EHR vendor doesn't do a massive import of clinical data or billing data or any patient data records from an older platform. Kyle, you mentioned that, you know, the issue that a lot of that information is maintained in different platforms in significantly different ways, and it just makes it extremely difficult to make that transition and move that data from your old platform to your new platform. So, you know, rightly so, people have just kept those old platforms alive you know, to continue to maintain access to those records for release of information purposes as is appropriate, right? That's going to have to, you know, that's going to be a bit of a sea change in the industry as a whole of how we deal with those legacy patient records. And again, let's remind everyone that this is not just the clinical record. So it's not just your EHR platform. These are billing records. These are records around coverage, insurance coverage, and that type of information as well. So there's quite a bit of information gathering that needs to be done to be prepared to support the Cures Act going forward for the next several years as it begins to roll out and become much tighter. Kyle, you agree with that?
Yeah, Jim, I think you make a great point. And, I shudder to think if, someone has maybe some paper records still in their file as one of their legacy type systems. But yeah, I think this is going to be one of the major hurdles that is going to have to be overcome for the 21st Century Cures Act, is seeing all of that data that's stored in all those different ways, as you mentioned, right? So hopefully no one has paper, but who knows, someone could still have paper, right? We could have systems, right? Yeah, we still have systems that have been retired, but they still work on certain organizations, computers, like you said, that people haven't seen or dealt with for years at this point, except for the Freedom of Information request, like you suggested. And I think we're going to need to see that healthcare organizations are going to need to do something to make sure that they can get that data into a system that is Cures Act compliant, that has those APIs, so that we can actually access that data, so that the data can be read correctly, make sure that the data integrity is correct. Because obviously, if we're going from handwritten notes, there's always little quirks in there, right? From transferring those notes to real-time data. So I think it'll be very interesting to see how everyone gets around their individual issues, as every organization probably will have their issue will vary depending on what type of system they had beforehand.
Yep, I think it's clear that the Cures Act will see healthcare organizations decide to better organize their legacy environments and move away from vendor-specific archiving processes to a true archive platform that is a newer technology, is quite a bit more secure, right, and has the ability to leverage the APIs required to be Cures Act compliant. Shannon, your thoughts on this whole gamut? Now that we've built out this entire slide, we're looking at quite an amount of data here, both clinical, billing, and nature, right?
Yeah. Well, yeah. Just to your previous point, it's hard to imagine retrofitting a legacy system with FHIR APIs. So yeah, I'm in total agreement with the best option being an archive platform, preferably in the cloud. That being said, so here I see I have lots of thoughts around this, because I'm a practitioner. So I think about both how it makes so much sense to work towards real interoperability, being compliant with the Cures Act, and then I see some challenges with actually putting this into practice from both a vendor perspective and undoubtedly through the lens of a provider. And I wouldn't be doing the provider audience justice if I didn't at least touch on information blocking in a tad more detail, because I know Kyle touched on it a bit, but it's worth at least shedding some light on how there is still ambiguity that has to be teased out here. So providers they're just going to have a lot of difficulty determining what constitutes actually as information blocking. So just a quick example, a doctor from a clinic's office, right, calls a local hospital because a patient was admitted to that local hospital. The office, the clinic, requests the hospital send information either directly or through the local health information exchange. Let's just assume that the clinic doesn't have Epic EHR, for example. I'm just throwing out a name. But the hospital's Epic system couldn't coordinate with the clinic's EHR, and it really wasn't designed in a way to help integrate with the local health information exchange. So this results right here as potential information blocking, and it's certainly not due to the provider trying to get the job done. it's definitely a technical issue.
Right, technological hurdle, right? Yep.
It is. And the second, I could give a few more examples, but the second example I'll give is a clinical perspective in terms of information blocking. And this is, an unexpected lab result. Kyle mentioned a cancer patient or a cancer diagnosis or result with a patient who has mental illness. Now, those are extremes. So between cancer and normal result, there's everything runs the gamut. And between a unstable mental health condition and stable mental health, there's everything in there. So you can see how the waters are murky here. And it is best to leave the judgment often to the providers, but how does that conflict with patient perspective, the regulation of information blocking? And I think it's something to consider for our providers and some of the conundrums that will hopefully be teased out over time.
Well, you would hope that that becomes less an information blocking issue than it is just a timing issue, right? So, if there's a cancer diagnosis, that provider and that patient get together and they have that conversation. And after that fact, boom, now you can do, the Cures Act information movement, but not expose the patient to more stress than or limit their stress as much as possible, right? So it's less a technological discussion than it is just timing. Have that conversation one-on-one with the patient before you start to exchange that information that they may be privy to, unfortunately, prior to a conversation, right?
I couldn't agree more that communication is the crux of this, and most certainly.
And I don't think that the government regulations are trying to subvert that at all.
No.
It's just it's very, very difficult to put that into legalese to say, have a conversation with your patient before you start exchanging data, right?
Of course. Another example, just to show how murky these waters can be, though, is from a legality standpoint. Generally speaking, parents and guardians have access to their child's records appropriately. But states have what are called minor consent laws that actually prevent the provider from sharing the minor's information with parents, especially when it comes to some sensitive topics like family planning, abortion, mental health, and substance use, I believe, and there's others. But it's drawing that line and knowing when to share and when not to share, and having the ability to intervene there that makes things more challenging. And diligence will have to be, put into play there when this information is being released and to whom. So just a little food for thought around some of the things that I think are going to have to be worked out a little bit.
So I guess that's a recommendation to get your legal department involved, risk management involved in this, right? It's not just purely, a technological deployment that's happening, right?
Right.
Yeah. And folks, that's why we have the Forrester folks on with us today, because me as a former CIO, I'm looking at most things from a technological standpoint. Shannon and Kyle bring a completely different view to things, and what we're really attempting to do here is give you a well-rounded understanding of the operational issues associated with the implementations around the Cures Act. So we have just about 20 minutes left. Shannon, Kyle, any additional comments before we open it up for questions?
Yeah, I was just going to say, in terms of the last conversation we were just having, I think we're bringing up some great points and some great examples where there's murkiness happening in there. And I think that's why right now, as I stated, yes, there has been information blocking complaints already, but there hasn't been really any action or punishment given out. There's been some talk, and it is written in there, like what the fine is going to be for an information network found guilty of it. But it's still kind of, we don't know, right? And I think it's because of examples like what you're saying. I think it's going to take a few years before we start seeing these examples and like what actually goes into them. And then on a state by state basis, what are the laws there, right? Because we can't just, I think originally they were going to blanket statement and say, it was up to a $1 million fine on anyone who kind of does information blocking. And then I think people started raising these ideas of like, okay, well, what about this kind of thing? And that's where they took a step back and they're like, okay, maybe we'll think about it first, kind of a
That's
thing.
where the exceptions come from, right? Probably.
Yeah. Right. Yeah. So that's where a lot of the exceptions come in. And even the exceptions, I think right now they have, to meet the exception, you need this, and this, 1, 2, 3, ABC. I think we'll start seeing, maybe 4, 5, and 6 start get added here, and maybe, a little side note added to this one, a little asterisk on that one. So I think it'll be interesting to see how it evolves over the next coming years, but I'm excited to see it.
Yep. It's interesting to me that that you mentioned that there are already patients that have filed complaints for information blocking, that it's, already these patients are aware that there's this rule out there. Now, we've seen similar conversations around release of information when maybe it wasn't as timely as the patient would have liked, or that type of thing. But I think the populace as a whole is so used to I hate to make an advertisement, but the Amazon model. I need toothbrushes, or I need dog food, and I can click a button and it's on my porch the next day. And healthcare data is not quite so simple, right? There's a lot of issues around it, and the organizations responsible for maintaining patient records need to be prepared to have that conversation with patients when they expect the Amazon delivery model, but there are a whole host of other issues to be dealt with. When meaningful use was rolling out, I actually had someone at a conference that I was presenting at for meaningful use that said, they raised their hand and they said, Jim, I can have my oil changed on my Chevrolet in Memphis, Tennessee, and I can drive to California and go to the Chevrolet dealer, and they know that my oil was changed 2 weeks ago. Why isn't healthcare that easy? I said, because your Chevrolet doesn't care if anybody knows whether it had its oil changed or not. That's just the reality. Healthcare data is much more personal, and it's not quite as open as maybe some people think it might or should be. Let's put it that way. So anything else before we open up for questions? Shannon? No,
nothing else at the moment, Jim.
Okay, so at this point, Stephanie, I'll ask if there are any questions out there, and we can spend our last 14 or 15 minutes rolling through any questions that have come up.
Yes, there are. The first question is, can a disruptive and new technology like digital pathology be considered an EHR?
I would say it contributes to EHR data. It is not in and of itself an EHR. So in the instance of digital pathology, you would have to include those records in a Cures Act download, let's say. But I would say to the organization asking that question is, yes, you need to be prepared to provide those records if necessary. Whether those records are stored in your EHR or stored specifically in the digital pathology environment. Shannon, Kyle, would you agree with that statement?
I think so. If I'm understanding the question correctly, then I'm absolutely in agreement with what you said, that it would be one component of it and not necessarily it's standing on its own.
Right.
Yeah,
I agree as well.
I think we've
Yep.
seen in Kyle's initial discussion about the Cures Act that this is all patient data. Whether that patient data is housed in a cardiology system and not delivered to the EHR itself. So, imaging environments, those types of things, cath lab movies, those types of things, those are ultimately going to be required to be exchanged between healthcare providers, as well as potentially delivered to a patient requesting that information. Sure. So hopefully
Yeah, so I would see them in there. And also when you think about it, right? So maybe you get those images on there and you want a second opinion. Well, it would need to be part of that record. So when you go get a second opinion, otherwise you do the whole process over, right? So I believe, right, it would be part of it.
And that's the goal, right? The goal here is to keep the costs down in healthcare. So yes, you need a second opinion. You share that diagnostic study, whether that be imaging or lab results or whatever, with that provider providing that second opinion, so that the patient doesn't have to go through that procedure again. Correct. Yep. Stephanie, any other questions for us?
There are. The next one we got was, do you know how the CARES Act will balance 42 CFR confidentiality protection for addiction diagnosis?
Wow, that is an extremely specific question. Shannon, Kyle, any input there?
I'm not a substance use disorder specialist. I actually cannot. I'm a little hesitant to speak too closely to that. I know that there's a lot of protective measures put in place for those patients. I even gave the example of the minor and that being protected even from parent-guardian exposure. But I'm not going to comment too much more on that. It's a little bit out of my scope.
Yeah, I think from a standpoint of a healthcare provider caring for a patient for something other than substance abuse, you would not share those records probably. Very much like a behavioral health record. Those are only typically shared when the care of that patient requires those to be shared. So,
and I'm pretty sure that consent is needed in order for the records to be released as well.
Yep. So we're gonna dodge that bullet at that point in time, and we'll go to the next question if there's another.
Yep. You mentioned getting Cures mandated data via a patient portal. Is this a EHR funded and maintained portal or a practice funded and maintained portal?
Well, I would say if it's an EHR portal, the practice is paying for it anyway. The EHR vendors typically are not, providing these services free of charge. I think the patient portal function, right now I could go to a patient portal and I can download copies of a lab result, for instance. I would say that functionality is going to likely have to be extended to say, Jim Leonard would like all of his records, and I want that transferred to my mobile app via the API. So that's where we're talking about these EHR platforms, patient portals, so on and so forth, having to go through an update to be Cures Act compliant. Shannon, Kyle, do you agree with that?
Yeah, I think so. I think it's a interesting distinction to ask, I guess, about between EHR funded or if it's going to be a practice funded thing, right? Because I think ultimately there are EHRs out there that have patient portals built into them that could already do this, and there are some that don't. So I think it's going to be a matter of, which vendor do you want to go with, kind of a thing, right? Do you want an all-in-one package? I'm sure price is obviously going to be considered in there, right? Like how much do you want to pay for XYZ? But I think it's also important to know that the Cures Act, it encourages the patient portal to get the patient data, but it actually doesn't mandate it to get the patient data. So if you're one of those organizations that doesn't have a patient portal right now and you're worried about getting in trouble for not having one, you technically don't need it right at this very second. There are other ways of providing the patient with their data or their entire health record that are acceptable. And that kind of goes back to that consent and manner exception that I was talking about, where you just need to basically discuss with the patient that, hey, we don't have a portal. Is it okay that we give you, a paper record or on a CD or some other format? So I think that's an important thing to know.
That's a great point. That is a great point.
Yeah, you did mention that. There just has to be a discussion between the organization and the patient to see what works best. Although I do like the fact that the ONC does encourage the patient portal. I'm sure there are studies out there with its usage, and I'm sure the numbers are fairly high if I had to guess, but yeah.
It's interesting when we talk about patient portals. I think most patients that are accessing a portal typically do that through, I would say, their primary healthcare provider, right? And if you look at those organizations that might be using, I'm just going to pick a vendor. Let's say they use eClinicalWorks in the physician practice, but in the hospital that owns those physician practices potentially, they might use Meditech. I think there's a discussion now that needs to occur because your patient's typical view into the portal is through eClinicalWorks. Are you as a healthcare provider expecting your patients to go to eClinicalWorks for their ambulatory data and go to another platform for your acute care data or your outpatient data? I don't know that, Shannon, you talked a bit about consumerism. I don't know that that's really very consumer oriented, right, to have that. So there's some level of discussion that needs to even occur at the healthcare providers about what's going to be our take on providing a customer-oriented experience to their healthcare data. Is it, our patients routinely access the eClinicalWorks portal? Are we going to get the acute care data fed to that eClinicalWorks portal so they can see their acute care data there as well? So that really brings up a really interesting set of topics that organizations need to talk about.
Yeah, you bring up just a loaded point, Jim. You do, because because balancing the multitude of EHRs for one patient, even when we just start, if I'm the patient and I'm in the Boston area and I have providers geographically within 10 to 15 miles, I could hit any number of different formats. And yes, we know that right now the information that's in those don't always coincide, and they don't always, they're not all standardized just yet. So I'm optimistic that at least implementation of the Cures Act from an interoperability and following the FHIR standards will help abate this to some extent. the idea of just one major EHR is, national EHR is music to some people's ears, and quite the opposite to others.
Talk to
But-
everyone in England, right?
Right, right, exactly.
Talk to the UK about that.
Right.
How
So,
happy
so
everybody-
I think this will be very interesting to see how this takes shape. And we are hearing about large mergers and acquisitions. Some of these vendors are getting some real power behind them. So it'll be very interesting to see what happens in the next 2 to 5 years even.
Yep, I agree. Okay, well, we are just about out of time. I want to thank everyone for attending the webinar. Hope you found it very worthwhile. I also want to thank Kyle and Shannon for their participation and their hard work preparing for this. This isn't something that we just show up and roll out. There's a lot of research and effort put into preparing a webinar like this, and I really appreciate your time and efforts at it.
Appreciate it, Jim. Thank you.
Yeah, thanks for having us, Jim.
All right. Well, thank you so much, folks, and enjoy the rest of your day.